Hello everybody, we're going to come to you today with a new educational delivery method. First and foremost, we always sort of brought educational big things to you at CE. Until earlier this year we had a really 4-alarm fire with our ketamine sedation needs, and so we tried the ketamine town hall. That was pretty labor intensive, so this is going to be a medical director WebEx channel that we're going to send education and positive feedback periodically to y'all. So let's try this out, let's see how it goes. Why did we bring this up today? Well, we've cardioverted a couple patients recently without sedation who were fairly awake and GCS 15, and that's not something that we want to do going forward. Discussing sedation and cardioversion is complicated, and we've probably not given as much direction and detail as we could have in the past. That can't stop us from trying to clarify and better educate going forward. But before we talk about sedation and cardioversion, what do we have to define? We have to define stable and unstable.
Yeah, so the biggest decision to make with these patients is to determine whether or not you feel the patient is stable or not. And so we do that by looking at all the factors in the patient presentation, and you guys are used to doing this, right? We're looking at blood pressure, their MAP, we're looking at skin color, presentation, are they diaphoretic or are they warm and dry, respiratory rate, are they tachypnic or are they resting comfortably. Importantly, we're looking at their mental status. Are they just sitting upright and talking to you, GCS 15, or are they kind of in and out of consciousness or confused and obviously not perfusing their brain well? Another indicator that I think we're all used to hearing from ACLS is chest pain. Now, I think that chest pain as an indication of someone being unstable has to be taken in the context of all the other things that we just mentioned. So somebody who is pale, diaphoretic, hypotensive, and says, oh, my chest is hurting because my heart rate is 180, that patient would be unstable. But someone who's sitting upright and talking with you and says, yeah, you know, my chest kind of hurts a little bit, but otherwise they look okay, I wouldn't call that patient unstable. And then another big tree here point that you make is whether the rhythm is wide complex or narrow complex. And in general, wide complex tachycardia is much more deadly. These patients tend to be much more unstable when compared against narrow complex, where the majority of these patients will likely be stable, although they sometimes can be unstable.
So if they are stable, and if you look at your protocols closely, there is no electrical option for stable, narrow, or wide complex tachycardias in our protocols. But that doesn't mean there's nothing that we can offer those patients. Pharmacology first, just like in our transcutaneous pacing discussion in recent CE. If they're narrow complex tachycardia, then we need to think about adenosine if it's SVT. If it's an underlying sepsis or dehydration situation, DKA maybe, fluids, if they're febrile, IV Tylenol. And then in the wide complex folks, if it is a stable ventricular tachycardia, then amiodarone is an option. If we think toxin, thinking back to our VTAC fat mnemonic, calcium and bicarbonate are both going to be players there. And remember that close monitoring and preparation and repeat examination is doing something. That is an action, that's a critical care action. So who do we sedate? That's the final big question that we struggle to answer, and we've talked through 25 times before this recording. Well, first off, on the stable, awake GCS of 15 end, we don't sedate, we don't cardiovert those patients. We don't want to do that going forward. If a patient is woefully unstable in extremis, GCS of 3, those patients need to be cardioverted if they're in a tachycardic rhythm. Those are unstable tachycardias. What about the middle portion, the patients that are altered and diaphoretic, and all of those unstable factors that you discussed? The more that are there, the more unstable the patient is. And those are always going to be judgment calls, but we do not want to cardiovert folks in our service here at MCHD without some sedation. And ideally, most times that's going to be ketamine. As always, you can consult your district chief if you have questions or if there are difficult situations, and those do arise from time to time. One last piece that I believe is important, especially for new learners. I know that I fell into the trap of symptomatic versus unstable. And this was summarized really nicely in a recent run review by Chief Hall, so I got to give him the credit. Just because a patient is dizzy or nauseated or has chest pain, for example, that doesn't make them unstable. We have to go back to their blood pressure, their mental status, their skin color, their respirations. And if all those check the box for stable, they can still be symptomatic and not require cardioversion. So this discussion is not finished after this educational episode. This is really more to try to get y'all talking and thinking out there and to try to communicate as thoroughly as possible. We're going to discuss this in Q4 CE, so keep your ears and eyes open for that. Send us feedback you have for this method. Keep doing good work out there taking care of our patients. Anything you'd like to add?
We're excited for this medical director channel. We're excited to be able to share really great success stories and good cases with you guys, and we love the feedback, so let us know how you feel.